England, and Jonathan Sampson, who's the Head of Assessment at NHS England. Jonathan is going to take us through the slides that we have today, and then we will, because I will add comments as we go through, and then we will open up the floor to you, for you to be able to ask questions, make comments, reflections, observations. We will finish at the latest at 1 o'clock, and if everybody has fulfilled all their needs in terms of questions and comments ahead of them, then we won't carry on any longer than actually people want. So without further ado, I'm going to hand over to Jonathan, who is going to take us through the slides. So over to you, Jonathan.
Thanks, Julie. Good afternoon, everybody. I've got a few slides here to present to you on the framework, the improvement assessment framework for 17-18 that was published a couple of weeks ago on the 21st of November. I expect much of this will probably hopefully be familiar to many of you. It's consistent with and builds on the framework that was in place for 16-17 and which we rolled over, albeit for a few months, into 17-18 whilst we were waiting on the publication date for the framework. So I was just going to run through some of the changes that we've made to the framework. The three things that we said we'd do last year, and that's what we've done. So we've looked at those indicators in 16-17. There were some areas where we said we'd develop some new indicators and introduce those in the framework. We've done that. We also said that we'd take the opportunity to review and retire those indicators where we'd seen a degree of improvement, and we've done that. And then there are some indicators where we've taken the opportunity to redefine the metric, either because the data source has changed or to make sure that it's a more meaningful measure for CCG's performance. So this is just to sort of remind colleagues around the background to the framework. Obviously, for the first couple of years since 2013, we had the old assurance framework. That was reevaluated and reissued as the improvement and assessment framework in March 2016, and that brought together in one place those core performance and other outcome goals and indicators that we would look at in terms of the assessment of CCGs at year end. That was aligned with the triple aim that we set out in the 5-year forward view. So it looks at getting better health and outcomes for patients, better quality of care, and it also looked at financial sustainability and getting value for taxpayers. And then in terms of the framework itself, there was a fourth area that looked at the leadership capability of CCGs and how they'd be working with their partner organisations. And alongside that, there was a commitment to be better, more transparent with that information and making it available to patients and public. So since September of last year, we've been regularly updating all of that performance information on the CCG pages on the My NHS website. So this is just to remind you, I'll just sort of run through it now. Those four domains that we've got in the framework, we've respected those and continued with those into 17-18. And then I just wanted to just sort of take stock around the year-end assessment that we completed in July under the new framework. We're not comparing like with like necessarily here, but in terms of those headline assessments, we've seen improvement in the numbers of CCGs that have been rated as either outstanding or good, and a reduction of those that have been rated as requires improvement or inadequate. And then beneath that, when you look at some of those individual areas in the framework, we have seen sort of significant improvement. So this draws out in terms of cancer, mental health and dementia, where over the course of that year we've seen improvement in those performance indicators by the majority of CCGs. So as I said, the framework was issued in November. We'd rolled it forward for those sort of first 6 months from 16-17. I guess number of sort of circumstances I think responsible for that delay. I think we had the publication of the next steps document, and then the election, and also wanting to look at some of those commitments in the next steps document around priorities, and also around, and we can talk about this at the end of the presentation, around assessments of ACSs and SDPs and what that might mean for the framework, particularly next year and thereafter. So in relation to this year, as I said, there were three areas last year that we said we'd develop new indicators on. So that was patient safety, patient and community engagement, and end of life. So you'll see in the framework new indicators in those areas. And we also took the opportunity to include 2 new indicators in mental health in terms of access to IAP treatments, and to learning disabilities around the completeness of the GP Learning Disability Register. So there's new indicators there, but they were in areas that had already been highlighted in the 16-17 framework. And as I said, we've taken opportunity to retire some and make some changes to a couple of other metrics that I'll come on to. And then finally, taking the learning from the approach to the year-end assessment in July, the framework sort of reiterates that the year-end assessments will be done based on performance against those IAF metrics, balanced against the financial assessment and the assessment of the quality of leadership. So I wasn't intending to go into too much detail here, but this is the list of indicators that have been removed. For a number of these, they've been wrapped up into a redefined indicator. So in terms of end of life and personalisation, we've captured those there. A couple of others around STP plans have now been captured in a slightly redefined assessment of leadership. There's 2 indicators here that, although they've been retired, around allocative efficiency, which we've drawn on right care data. We expect for next year that we will be including a slightly differently defined indicator around demand management that would be based on that right care data. So it's 2 of them out for this year, but I think we'll look to introduce those in a new way in 18-19. And then on here we've got a small number of indicators that have been redefined in some way. And this is either because, as I say, the data source has changed slightly, or that we're wanting to make sure that it's a more meaningful measure for CCG performance. And we've also made some changes to where one of the indicators, maternal smoking, sits in the framework. So that's moved from better health to the better care domain, where it sits alongside the other maternity indicators. So this final section, this I think will probably be familiar to many of you. So this is the indicators grouped against the 20-odd areas we've got in the framework against each of the 4 domains. So in better health, which is actually where we've got 7 areas covering off 9 indicators. So that covers child obesity, diabetes, falls, personalisation and choice, health inequalities, antimicrobial resistance and carers. and for all of those, I think it's the existing indicators that have rolled forward from 16-17 into this year. We've then got the better care domain, which is quite where the rump of actually the indicators sits. So we've got 13 areas in here with 34 supporting indicators. So that covers off high quality care, the cancer indicators, mental health, including some new indicators around IAPS, as I mentioned, and updates to 3 of the indicators that were included last year. We've then got learning disabilities, again, where we've got that new indicator on GP Learning Disability Register, the maternity indicators, including the movement of the maternal smoking at delivery indicator from the better health domain, dementia, urgent and emergency care, end-of-life care. There's a new indicator, as I said. We've got primary care, elective access, 7-day services, NHS continuing healthcare, and the new indicator on patient safety that is looking at sepsis awareness. We've then got the final 2 sections. So we've got the sustainability section, which slightly reduced actually in number because of the retirement of those right care indicators, as I said, where next year we intend to introduce an indicator around demand management. But for now, it's the in-year financial performance, and which is the existing indicator, and the existing indicator around paper-free and e-referrals. And then we've got the final domain that looks at leadership. So again, much of this is consistent with last year's framework. So we've got probity and corporate governance, workforce engagement, CCG's local relationships, where we look at the evidence from the 360-degree survey, the new indicator on patient and community engagement, and finally the quality of leadership indicator, where we have slightly redefined that to take account of contributions to SVPs and working with partners as part of that SVP partnership.
Before we go on to the 18-19, I just wanted to add a little bit of context about how we got to the new list that we've got for this year. So one of the things, for example, I came to Julie's board and met with NHSCC board members shortly after their new board was elected. And we talked there about the priorities for the NHSCC board in terms of what the framework for 17-18 would look like. And I would say there were really 3 key messages that have come through very strongly from that and from other feedback that we've had directly from CCG to our regional teams, and indeed from our regional teams themselves. The first point was a real desire from everybody not to have any radical change to the 17-18 framework, which you can tell me otherwise when we come to questions, but I think that we have achieved. Also a request to reduce the overall number of indicators, and I am glad to say that we are going from 61 last year to 51 this year. The other key message was the desire to protect, in that reduction, the domains around the clinical outcomes, that for fairly, I hope, self-evident reasons, the most important things to CCGs and to us were the clinical domains that were within the CCG IAF. Now, within that, there were some specifics. So, for example, on mental health, the indicators that we had last year had relied on a specific bespoke collection on Unify, which I sensed everybody had found a little bit time-consuming and didn't want to be repeated, which we were absolutely happy to go along with. So I'm glad to say on those ones particularly, we have swapped those out with things that we are now able to report data on, which makes sure that the IAF is more closely aligned with the overall mental health programme and the data that we are wanting to report and the particular outcomes that we're wanting you to prioritise in those. And that was all I wanted to say on that, and I'm obviously happy to answer any more questions before Jonathan goes on to say something about what we're intending for 18-19.
Can I just chip in there, because I think that's really helpful, because I think the other point, and it links to your first point about reducing the number of indicators, was make sure that we don't increase the burden and that we try to reduce the burden, not just in the number, but in terms of process and attention, because CCGs, as we all know, as you will well know, are under extreme pressures and from all sorts of fronts. So we need to make this as useful for them and their communities as it is for NHS England to fulfil its statutory assurance role that is laid out in the Act. So yeah, I think you listened. So thank you for that. So hand back to Jonathan then for next year. Will we talk about this year?
Yeah, so finally, I mean, that was just sort of looking ahead then and, to next year and beyond. I think there's two drivers there. As Julie mentioned, obviously we've got the legislation, so that sets out a requirement on NHS England that we must do an annual assessment of CCGs, and that's done under the auspices of the Improvement and Assessment Framework. But also, as I said, we've now got the publication of the next steps documents and increasingly movement around towards SVPs and next year those pilot accountable care systems. So that next steps document also commits NHS England working with NHS Improvement to develop a single oversight framework that would integrate the CCG IAF with NHS Improvement's single oversight framework to give a sort of single system oversight, single system assessment framework for ACSs. So that's where we're looking, a lot of work going on the moment around what those metrics might look like for system assessment. And we also need to think about how that interfaces with and what that means for the CCG IAF next year and beyond. So we'll have 8 accountable care systems, I think it is, from April next year, involving not an insignificant amount of CCGs, but there'll obviously be a lot of CCGs that won't be part of that those new system arrangements next year, where we will still need to be doing an assessment of the CCG. So I think this is an opportunity really to get reflection on people's views around what the ambition should be for the IAF next year.
Yes, and again, I think you've listened, because that has been a consistent ask from NHSCC, actually probably going back about at least 2 years now, to say, please, can we have a single regulatory and assessment approach across the system that covers commissioners and providers, and it's definitely not from where we sit. Putting the two together and job done. It's got to be something much better, and I'm sure it will be than that. So we are committed to getting involved in the development of that with NHS England and NHS Improvement colleagues. But it would be really helpful to have your thoughts and reflections on what you think about that, and what you might want it to look like, and perhaps what you don't want it to look like, so that in the design we can try to reflect some of that. But so the floor is now open to you to submit your questions, comments, reflections on 17-18 IAF and what you've heard, but also to talk about 18-19 and this move towards a single oversight framework. If you wish to speak, you can also do so by you have to click the hand button, and then it should open it up, and you should be able to actually speak. We'll unmute you to be able to do that. But if you're in noisy surroundings, if you can mute yourself if you're not speaking, Otherwise it will be difficult. So please do now submit your questions, comments, thoughts on what you've heard so far.
And Julie, just while we're playing with the technology to understand how the raising of hands can go on with me, I would also say that we are always open to comments and feedback, and at the end of the webinar we will put up the mailbox email address which comes directly through to Jonathan and his team here in NHS England National organisation. And of course I would encourage CCG to discuss this with their local NHS England counterparts,
yes.
Particularly around what 1819 will look like going forward, because this is still in development, and so NHS England teams will also be being asked to think about what the system oversight model could look like for 1819 and for beyond, right, in relation to ACSs.
Yeah, great, thank you. One point in terms of 1718, I just want to sort of flag it really to colleagues who are listening in, is the patient community engagement indicator that links to the guidance that came out earlier this year. We held our lay member network annual event last week, and this was talked about, and what was a little concerning is that there was a significant number of lay members in the room who didn't know about this guidance. And it's very robust, and actually very good, I thought, when I read it, and just a plea to make sure that that the right people in your organisations have seen this guidance, so that when you come to be rated against it, you're not blindsided on it, because I haven't actually seen it. So that was just a worry from my point of view.
That's really helpful to know, and I'm glad that you think it's good guidance.
Yeah.
It's
quite challenging.
It's not an easy area to assess and measure. Yeah. Some places are fantastic at engaging with patients and communities, but it's a very difficult thing to tick a box or to collect data on, because it's fairly subjective. And so I think actually this guidance does really move us on in terms of being able to assess that in a more systematic and probably a fairer way.
And it's how CCGs are able to demonstrate that, because what I think, and this has come through the early assessments, that people are clearly doing some wonderful work in relation to a piece of redesign around diabetes or whatever, but actually it's not coming through in terms of either their board papers or their websites, and so actually they're not able to demonstrate it, and then find that they're struggling, they're not going to get a good rating out of that. So there is something about that needs to come through, and obviously we'll play our part with our lay members, but it's a much broader issue.
And then Julie, you mentioned, I think CCG's, the policy team in NHS England have provided to CCGs a sort of an initial assessment based on some of the desktop research that they've done, and I know they're willing to identify what action could be taken to make sure that year-end assessment has been improved. If that's
and your lay members have all got that initial outcome, because I've seen some of the emails which are helpful in terms of this is what you might think about doing to actually move wherever your initial assessment is essentially going. So
some of that is relatively straightforward, and obviously this is the first time that we've done it, so there may be teething trouble, and please do let us know and make sure that your lay members are able to through their lay members network if necessary. But some of those are very simple tests. Someone has gone onto the CCG's website, looked to see how they would get involved or what the result has been, and not been able to find it. Now, if that's been done by a member of the admin team here in NHS England, then how do you think that patients would be able to find that information either? And it should just be a case of ensuring that web links are easily navigable, and then providing that evidence back through the route that's been outlined in the initial assessment. If there are CCGs who are wondering what on earth we're on about, then it may be that you had a perfectly positive outcome from the initial assessment and don't need to go fixing web links. But hopefully those of you do know what we're on about if you've already had an indication that things couldn't be found.
Okay, so we have a question. Will there be dual running of the IAF and the SOF during transition, and when will the CCG IAF come to an end?
Shall I go at that? Well,
yeah.
As I said, we've got the legislation. So as long as we have CCGs, we will be required to do. NHS England will be required to do an annual assessment of their performance. In terms of next year for those ACSs, I think what we're looking to do is to pilot that system assessment framework. So that would be those small number of indicators that NHS England and NHSI would be looking at in terms of the performance of that system. And I guess that would probably be around sort of leadership, finance, and those sort of constitutional commitments and performance standards. For next year, we'd still have the CCG IAF, so that as NHSI would still have their oversight framework, so that would be looking at those organisations that are part of the ACS, and that would remain in place. Now, then it might be that we would want to evaluate for 1920 how we might want to make any moderations to the CCGIF in light of what we're tracking at a system level. But as long as we have those organisations, I think we will keep some guides of that framework, and it also provides quite a richness of information that you would lose if you aggregate that up to a system level. So if you look at things around sort of health inequality, engagement with patients and public, as we've talked about, that's something that I would have thought we might still want to be looking at in terms of those organisational footprints. So I think it will be an evolving picture. Perhaps we see next year as sort of transitional with those piloting with those ACSs, and then we will need to evaluate that, look at what that will mean for further rollout in 1920 and beyond.
I think that's right. I mean, I would just say that in terms of that being a fairly simple question, there's also a very simple answer, which is that there will be a CCG assessment for as long as there are CCGs.
Yeah.
And Jonathan is absolutely right that through 1819 we will expect the nominated ACS to be working through with NHS England and NHS Improvement on behalf of the whole system how we actually make that work, and then we would hope that in 1920 more organisations within the system will be part of an accountable care system and will therefore take up on the learnings that the initial SAT have done for us. I think there's one other point that I would make on that, which is that for us and for CCGs, for commissioners generally, this is in many ways an easier process than it is for NHS Improvement and for providers. Because when we look at what we expect from a system, they are a lot more of the things that commissioners are already used to having to think about. And so the wider implications on childhood obesity or falls are things that commissioners have always been thinking about and have always been working with the local authority to improve. And it is providers who are having to catch up with us on that journey.
Yeah. So and I think so some of the access targets that a welcome alignment so that you have a single focus, and because we often have conversations, certainly in the CCGIF delivery group, where a health system is struggling on its access performance,
whether the Commissioner is doing all it can and actually the issue is about a trust issue, provider issue, or whether there's more that the Commissioner should be doing. And if it's the latter, then that should understandably affect the CCG's, if you like, assessments to some extent. But if it genuinely is the former, and actually the CCG is doing everything it can, and actually it can't do anymore, then it's a different issue. So how we tackle that is going to be really important.
But of course, overall, that is a system issue, and it is an issue for patients who are in that area.
Yeah.
So it
puts everybody, gives the ownership into
everybody on the same
one or other.
On the same hook.
Yes.
And so one other thing worth mentioning is, in terms of the questioner about when will it end.
That plea.
I hope not. We have agreed with NHS Improvements that for the foreseeable, all existing data flows will continue. And so data that's collected from trusts by NHS Improvements, that will continue. Data which is collected by us, those data flows will also continue.
Okay, we've got a few questions about the clinical priority areas, so we'll take them together and then see if we answer them. So, in case it doesn't come up later, are we able to get an update on the clinical priority areas, please, for the assessments for the 3 that haven't been released, and as well as the plan going forward? Then, what about why is respiratory not included? And then another one around, and that's the same one about the clinical priority areas. So they're the 2 questions around those.
So on the clinical priority areas, that's right. So the mandate that the department gives to NHS England required that there would be independent assessment of CCG performance in 6 clinical areas, and those assessments were derived from those indicators in those clinical areas that are in the IEF. So 3 of those, I think, were issued in July at the time of the year, and assessments were released, and there were 3 remaining, and those were so that we could make sure that we took account of the latest performance data relevant to performance during 16-17, and for those 3 areas it wasn't available in time for July. I know that for one of those areas the data has become available, and I know the panels have considered that in relation to diabetes, and I think we're hoping for the panels to release those assessments, I think, maybe within the next week or so. I think for the remaining 2 around maternity and learning disabilities, I think there needs to be some further work to make sure that that there has been a refresh of data, performance data for 16-17. Otherwise, those assessments wouldn't have moved on from where we were last year.
On maternity, that's a particular issue because 2 of the 4 indicators are based on survey data from the CQC survey, which wasn't run. So there is literally no update to half of the assessment from the baseline assessment, which is less than ideal and may mean that we need actually to delay essentially for another year on those indicators. On learning disability, again, I think there are particular data issues, and you will have noticed in the preceding slides that for learning disability for this year, we have included the additional indicator to pair up with the health checks indicator about people with a learning disability included on a GP register. Yeah. So really to indicate how continued importance on learning disability, on transforming care, and overall and improving health access for people with a learning disability is important for 17-18, but for particular reasons around data, it may not be possible to do the in-year assessment for last year.
Right, okay. We have actually lost one of the questions, so if your question doesn't get answered, and I'm sorry, I don't know who asked it, can you put it back in, please. We're also hearing the audio has been bad and patchy. Can the link for the session be sent out? Yes, it will. The link will be sent out for this. So the question.
Do you want me to pick up the question about respiratory?
Yes, please do.
I mean, it in a way you could switch out for respiratory and insert any other clinical priority. The other one that I often get is neurological conditions, but I get pretty much all of them.
Children, older people.
Absolutely. So we have got some older people. We are trying to get a balance without having all of the 260 odd things that are really, really important for the NHS, at least. Yes. We are trying to not ensure that we assess against all of them. You will know what are the particular priorities for your population, and you will be pursuing those with vigour. And I would hope that that would come through in many of the elements of this. So, things will be being measured through access targets, for example, or if not, then through the leadership domain. But we can't cover everything.
No. And the Secretary of State has specifically identified some of those critical areas in the mandate between the government and NHS England, so that has driven some of these thinking.
The mandate is our vehicle for our democratically elected leaders to tell us what the particular priorities should be for the NHS. So those are the things that we have to take very seriously.
Yeah. So there was discussion earlier about having national clinical dashboards for each of the clinical priority areas, and currently mental health and cancer are available. Will others become available?
I don't think I know the answer to that. I think that there is a dashboard around urgent and emergency care. I don't think that there is an intention that there will be a dashboard for diabetes or for maternity or for learning disability. But I'm not sure about whether for everything that's the case.
Yeah.
It would be interesting to know from the questioner how helpful and useful they find the specific dashboards on mental health and cancer. If the kind of expanded set of metrics made available through a dashboard is a particularly useful way for you to delve into the detail of what is driving your performance on those, then please do give us that feedback, and we can offer it to the relevant policy programmes.
What we've tried to avoid is the development of a whole range of metrics that then somehow just get added to the burden of assurance. So if there are good metrics because they're good and they do drive performance, great, but it's a balance between what goes into the IAS and what, if you like, sits alongside it as useful things to measure yourself against. So getting that balance right is important. But it'd be good to get your views. Is there any guidance on how the end of year CCG assessment will be derived under the IAS for the end of 17-18?
Well, as I said, the framework has a sentence or two in there about the approach that would be taken. It says it'd be just like last year, where that assessment is made on performance against the suite of the indicators in the framework, balanced against the leadership rating and financial management. When we did do the year-end assessment last year, we released a detailed methodology manual about how the year-end assessment had been done. So that went through each of the indicators, how they'd been banded and scored to come up with the overall assessment. And I think we'd be looking to replicate that this year, albeit with a slightly fewer indicators where we've made some changes to some of the definitions. But I would have thought hopefully we've established the principles, and we'd look to apply those again in July.
I would reiterate that's it's not a trick question. Well, it's not a trick answer rather. That is the way that we came up with the overall scores at the end of year. We would intend to replicate that. So the performance metrics on one side, leadership and finance on the other side. And if you are keen to understand at what standard deviation you get a particular rating and then how that is combined, it is all set out in the methodology manual, which went up on our website at the same time as the end of year results and should be accessible from that webpage.
There is a plea for the methodology manual to, when it's refreshed, to be released earlier.
We can try and do that.
Yeah.
I wouldn't anticipate that there would be any particular changes from the detail that will sit behind the calculations on how indicators are banded and scored and then summed. So look at last year's. Would be my.
So look at last year's. The other thing to say on that, in addition, is the process of sort of moderation and scrutiny that happens. So I have the privilege of sitting as the only external person on the NHS England CCG IAS delivery group, where the whole output of all of the work that colleagues do across the country with their CCGs to come up with, if you like, the scores on the doors, comes to, if you like, for scrutiny and oversight and moderation to make sure, particularly in some things like the leadership indicators where there's a degree of judgment, to make sure that actually, the same sort of judgment is applied if you're in Leeds or if you're in Littlehampton, for example. And in addition to that, last year, and I hope we can replicate it this year, we have NHSCC board members actually sitting as part of the regional moderation, so not from their own region, but CCG, either chairs, chief officers from our board, who sit with NHS England colleagues as they work through the detail of each of their CCGs across their region. And last year, the feedback from both the NHSCC board and I think from NHS England colleagues was that it was really, really helpful to understand the real robustness of the assessment and, if you like, moderation at the regional level and challenge to get to the right, if you like, assessment outcome for each CCG. And I certainly have feedback from both sides that both found it helpful, and we'd like to replicate that again, because actually it's really helpful for people to see. So they're not there to actually change the score, but they are there to challenge if something feels like it's not right or it's not a logical conclusion from what they're seeing. So hopefully that's helpful, and then I do it at a national level as well. So and it is a very robust process.
I would hope so.
Feel like it from your perspective.
I'm glad to hear that feedback again. I mean, from our point of view, there is nationally agreed criteria around the subjective indicators, particularly around leadership, which NHS England colleagues test each other against, and they take it very seriously.
They do.
So it is done first at a regional level, with all DCOs coming together and ensuring that they have been consistent in their application of the criteria around leadership. And it is then done again nationally to ensure that all 4 regions have calibrated that in a consistent way between the 4 regions.
Thank you. So the response to the question about clinical dashboards, they are helpful and enabled from level of comparison with other areas as well. I know you sort of see that.
We can definitely take that back.
Great.
Careful what you ask for.
Yes.
End up with more and more dashboards, but certainly we will pass that on to the existing dashboard owners.
But it's not to be used to beat you over a stick with a stick. So that's the important point. Okay, so the question that we lost, I don't think I have got back yet. It was something about next year. So if if you can come back in with that question, because it's gone. That would be good. On the end of year assessment, can you say anything about weighting between different parts of the AAS?
I think as we've adopted the sort of same language in the framework this year as last year, so it is balanced. So the performance indicators balanced by leadership and finance. So I think the weightings last year was sort of 50%, 25, 25. As I say, I couldn't think why we would change that.
Yeah, I mean, finance and leadership, can't overestimate how important they are to be making sure they are covered off. So all of the other indicators are also absolutely important, and that's where all the critical ones are in there. But actually, if you slip up on the leadership ones, then you will find that will have quite a big impact on the.
You will, and it's not going to be a surprise to anybody to know that it is hugely important where you are on finances. If you haven't had that message,
I'm sure you have.
But it is also important to say, without wishing to reveal too much about the internal debates that we have here at NHS England, it is not the only factor.
No.
And there are cases where it's not the deciding factor. If you are doing phenomenally well on lots of things that you have slipped on money, that is not always the case that you will find yourself immediately into the bottom bucket.
And it depends why you've slipped on money.
It does largely depend why you've slipped on money.
Yes.
But it's also the case that you can't slip on money, but do amazingly on everything and go, well, we're doing amazingly on everything, so it doesn't matter that we slipped on money.
Absolutely. Okay, so as well as the demand indicator, what other changes can we expect for 18-19? And would it be possible to have sight of the detail and technical annex ahead of the 1st of April 18?
So, shall I pick up the second of those and you pick up the first?
Yeah.
So on seeing it ahead of 1st of April, I think that is unlikely. Our steer that we've had is that the indication is that we will be doing that after we do the 18-19 assessment. So rather than overlapping, essentially 17-18, yeah. So rather than overlapping, we would do those consecutively. We've been audited on the CCG IAF. Our internal auditors have taken us through our paces on this, and that is one of the things that they have told us that we should be doing next year. So I would expect to see the 18-19 version, whatever that will look like, in a single system oversight and assessment process after the end of, in Q2 of 18-19.
So hopefully not this time next year.
Hopefully not this time last year.
December feels late.
November, it was November. November feels late. Yes, happy Christmas.
Yes.
But it won't be March.
Yeah.
And partly that will be important actually in order that we can work that through thoroughly, what that 18-19 process is going to look like for everybody, as well as for the accountable care systems who are going to be help working that through, what that system process looks like.
Yeah.
In terms of specifics.
In terms of the specific, I guess we've started from the sort of approach where we would assume that we would still want some sort of consistency and stability from last year's framework into this year and for next year. So I think we would want to hold to that. So we'd be looking to make, minimal changes to make sure that we don't add to the list of indicators, and if we can bring that down further. As I said, we do know there's the demand management indicators to be added. It may be that we're required by the mandate from the department to include new priority areas if they're set by the government, and I guess we'll know that sort of into the new year. But I think we're wanting to adhere to those principles around sort of continuity and stability, and to be trying to reduce within that the burden of some of the data collections and the numbers of indicators.
And Jonathan, I'm not an expert on the NHS improvement single oversight framework, and neither are you, but I think we're both rapidly becoming more familiar with it. Are there any elements that NHS improvement are likely to bring to the system oversight framework for next year?
So their frame, if you looked at it, very, in terms of the broad headings, there is consistency. So I think what we're saying for commissioners and providers is the same things matter. So it's around leadership, it's about finance, it's about quality, and it's about sort of performance and outcomes for patients. So you would, yeah, but that's there. They've got their single oversight framework. I think that their headings are very similar. So it's you can quite produce that sort of Venn diagram that has that overlap. There are some things that we look at that are particularly around the sort of the better health, where we're looking at the health of a population and how we focus on improving people's health, so we reduce that demand curve in the future. I think that's something that's probably not captured by an agile SOF, but it is something that as a system we'd probably want to capture in that oversight framework.
And in their SOF and not in the IAF, and I hope wouldn't be a focus for CCGs, would be some of the more operational metrics about how a trust works to deliver access targets and things like that. So it's about trying to make sure that we've got some of the operational metrics that are focused towards the delivery of either provision or commissioning that are right, and we don't just burden everybody with metrics that actually a commissioner, a CCG wouldn't see, because it's about, I don't know, throughput and all that sort of stuff. But would need to understand what's going on about it.
Well, Julie, in a way I disagree, because if those are things that are important for the system, then they will need to be things that all parts of the system pay attention to and help each other to improve.
Yes.
So it may be that we're not going to expect everybody at the system level to get into the detail of how a trust operates, but if those are the indicators that drive the overall performance of that trust, and that trust operates within that system, then they do matter.
They absolutely matter, and it's how then the system, the place, holds the different parts of that system to deliver that. It goes back to the conversation we've had before about things like smoking cessation and obesity, where actually the local authority plays a key role, and the Commissioner's role is to CCG's Commissioner's role is to influence, and not necessarily, it's not within its control to really deliver everything on that one. So
no, I'm going to continue to disagree with you. I am expecting providers now to start to take an interest in those discussions with the local authority about those things that are out with the traditional boundaries of the trust. And the balance for that, the quid pro quo, is that it may need commissioners to become more involved in some of the specific metrics that drive the trust performance.
Yes, it's getting that balance right. It either becomes, there's a danger in making it everybody's business, it can become nobody's business.
That is a perfectly reasonable proposition, and I will agree with you on that.
Okay, on that note, we have agreement. And a final question. For the new indicators, when can we expect data to become available in the CCG scorecard?
So I don't know the exact dates. I know now on the My NHS website, though, we've got a table on there that lists when the data release will be for those indicators that data is still outstanding. So much of the data in there is refreshed sort of monthly and quarterly. For those that are annual, we've got a date, and what we're making sure is that all of that is available, so it can go into the year-end assessment that will be done in May and conclude in July.
Okay. And for some of the new indicators, for example, the patient participation one, which we've talked about already on this webinar, that will only be a final end-of-year assessment, but there has already been an initial assessment done. That's not going to be published, but it is being fed back to CCG, particularly where it looks like the answer to the assessment may be less than glowing.
Okay. Another comment, I think, more of the questions. There is mention around national guidance to regions aimed at steering senior discussions around CCG IAS.
I think that was perhaps mention of the criteria around assessment of the leadership domain.
Right.
Which is available somewhere.
So yeah, so alongside the very short 6 pages, I think it is, the IEF, there is a rather detailed technical annex which goes into a lot of the...
Not 6 pages.
Which is not 6 pages, no. Which goes into quite a lot of detail around how they indicate, how the metrics are derived, denominators and data sources. I think much of that is probably academic, but I think colleagues will want to look at particularly the pages around the leadership metrics and on finance.
Absolutely, and I would strongly encourage everybody to get to that. I know that the leadership one is, I can't remember which page, something like 130. It's a long way down, but I have pointed it out to a number of CCG chief officers before, because it's there and it does explain the things that will be looked at and the judgment forms that. So forearmed is forewarned and all of that. I would strongly suggest you look at that.
It is a long document. It should be navigable, so you should be able to click in the list that says what indicator you're interested in. You should be able to click down the bottom there, the quality of leadership indicator, and it will take you directly to the right part of the document. I would just like to flag, though, we are aware that there is a little bit of an issue with this document around accessibility, compatibility. So if you are using a screen reader and you are finding that tricky, apologies, and please do let us know via our email, which should be on your screen now, england.ccgiaf@nhs.net. So let us know that that's problematic, and we will get to you in another format.
Okay. Just before we finish, reminder that on the leadership one, there's 5 elements. So probity and corporate governance, which includes conflict of interest, yes, which is really important that you look at, and there are some clear requirements that need to be undertaken by the end of March. Workforce engagement, staff engagement index, which is using the NHS staff survey. One of our NHSCC network, the HROD Leads Forum, has been having conversations about that, but a lot of CCGs don't currently use that, and if you don't, you will immediately score badly in relation to that. So do please look at that, but also progress against the workforce waste equality standard. And then CCG's local relationships, which is looking at, and that's where the 360 degree comes in, looking at effectively working relationships in the system, both with member practices, trusts, but also local government and so on and so forth. So that's important. Patient public engagement, community engagement, we've talked about, and that whole raft of guidance there. And then the quality of CCG leadership. So although it says leadership, actually there's a lot of other stuff that is broadly about important things to do with having a well-led CCG. So really important that you give due time and attention on that one. So we have now come to 12:59, and we've also concluded the questions. So I think that is a perfect time to thank Jonathan and Keziah for their inputs and their frankness, which is also very much welcomed. Thank you.
Thank you for having us.
Thank you for participating, and we will get the slides and the audio on our website, so you can listen again, read again, and share with colleagues. And if I don't get to see or speak with you again, have a really good Christmas break and a healthy New Year, and let's make sure we do the best thing for everybody. Thank you, and goodbye.